A lot of people with asthma. All right, in patients with asthma, the bronchi and the bronchioles, remember, go back over your anatomy and your physiology. The bronchiole and the bronchioles are chronically inflamed and can become so inflamed it leads to an asthma attack. This will cause the patient to experience wheezing, chest tightening, and shortness of breath and coughing. So let's dig into these structures in our body and all that kind of stuff. So when you have your bronchi and your bronchioles, these are smooth muscles, right, that wrap around your airway. These muscles help with dilating and constricting the airway. So during an asthma attack, these smooth muscles constrict, right? This causes chest tightness and difficulty breathing. So basically, this muscle does just this. It constricts and dilates, right? But during an asthma attack, it goes like this. All right. So what is inside these structures? So inside these structures are mucosal linings, which contain special cells called globulate cells. All right, and your globulate cells, they produce mucus, which helps track the bacteria we breathe in and prevent these substances from entering further into our respiratory system, right? All right, so during an asthma attack, the mucosa becomes very inflamed. This narrows the airway, decreasing airflow, and air becomes trapped in the alveoli. These globulate cells produce excessive amounts of mucus, hence leading to further decrease in airflow. So this patient may start to cough, they may start to wheeze as the air tries to flow through that narrow airway and around the mucus, which makes a whistling sound. Now does this make sense? All right, so during this, air is being trapped in the alveoli. Therefore, gas exchange is not taking place. So there will be low amounts of oxygen entering into the blood. The patient will have decreased O2 stats. And carbon dioxide is staying in the blood. So this patient will have what? Increased CO2 level. So increased CO2 level, what is that looking like? Respiratory acidosis. So the patient will feel like they cannot exhale all the way. So let's look at our picture right here. So we have our bronchiole and our bronchi, right? So we have our relaxed, smooth muscles. You see how it looks? Let me grab my laser. So we see how it looks in the normal, right? It's nice and normal. And then you can see that air would be able to flow through here, right? But as we see in this one, that it now has become inflamed, right? Uh-oh. So look how much airway we have to breathe now. This is an asthmatic airway. This one is an asthmatic airway during an attack. Do you see how that airway is so narrow? So basically, during an asthma attack, basically there's constriction, there's bronchial spasm, and airflow is not being able to go through. And if air is not being able to go through, then guess what? Carbon dioxide is not being able to go out. So this patient will be in respiratory acidosis. So what are some risk factors for exacerbation? So a patient could have asthma and they haven't had an asthma attack in years or in months. Why? Because they know their risk factors for exacerbations: allergies, if they get sick, respiratory infections, exercise, right? Weather changes, hyperventilation. So we want to be able to teach our patients, if they know their triggers, to first find out their triggers, and once they find out their triggers, then stay away from them. So we're not going to go deep inside how it's diagnosed and everything, but they can do a pulmonary function test and also look at the patient's signs and symptoms of what they actually have going on. So what are some signs and symptoms of asthma? We kind of all know that, right? We kind of all know that the chest tightness, right? The wheezing, right? We having coughing, difficulty breathing, especially breathing out, right? Increased respiratory rate. And this can this can lead to your patient, this can lead to a very serious thing happening. This could lead to like death or something. The patient has an uncontrolled asthma attack, because what can happen? That patient now can, the brain can then go without oxygen for all the time, the heart without oxygen that it needs, the body without oxygen. So we want to make sure that the patient is able to recognize that they are having an asthma attack and then treat it. So we have our relievers, right? We have our reliever inhalers right here. And relievers works within 5 to 10 minutes, right? And that's what we want to do, our relievers. All right. So then we also have our preventers, right? Our preventers are ones that, so relievers, we take our relievers during an asthma attack, right? Our preventers, those are the inhalers that we take to prevent, meaning those are when we may take 1 puff a day, 2 puff a day. It's just to prevent, right? But we have to know the difference between the two, because we can't take a preventer during an asthma attack. Does that make sense? Go back to your pharmacology, review your inhalers. I will post the slide of the inhalers that I want you guys to know. But when I post the inhalers, I want you guys to know, put it in the category. If this is a preventer, if this is a reliever, if this a combination one, and a combination one which they kind of may do both at the same time. But we know for relievers during an asthma attack, we're going to get our reliever inhalers. So you want to make sure your patient knows how to work an inhaler, and if they're on multiple inhalers, which your patient probably is, that you need to really explain to them what is happening. So as you can see this picture over here, that if a patient's asthma is controlled, the airway is good. So the airway is relaxed muscles, no airway swelling, no mucus, especially when you're using your preventers and stuff. All right. Let's go. So, but when you're using your reliever, when you're just using your, so this is how you are doing, right? This is how the constriction, do you see the constriction in this area, right? But when you relieve, you use the reliever, you give it 5 to 15 minutes, what ends up happening? Your muscles end up releasing, right? It ends up relaxing, right? And as you can see, as it relaxes, guess what? More air is able to flow in there. But when you use your preventers like you're supposed to, and you're consistent with your medications, you could have a well controlled asthma where you're relaxed, you won't have no airway swelling, no mucus production. All right, so next is status asthmaticus. All right, so this is a life-threatening complication of asthma, whereas airway obstruction is unresponsive to usual therapy. So let's say that the patient took their inhaler, is not working, they got breathing treatments, is not working, nothing is working for that patient. So this leads to accumulation of air in the pleural cavity, right? Because they can't what? They can't expel the air, right? They can't push the air out. So that increase, that accumulation of air in the pleural cavity, that is called a pneumothorax. And that can lead to cardiac and respiratory arrest. So we will talk about pneumothorax in class. All right, so what are some signs and symptoms of this? Extreme shortness of breath, extreme labored breathing, where the patient may be not able to even talk. They're so short of breath, they can't even talk. Normally during an asthma attack, somebody's having an asthma attack, they can be like, girl, I'm having an asthma attack. Girl, I'm having an asthma attack. I can't breathe. I can't. That's what they normally say. I can't breathe. I can't breathe. I can't breathe. No. In status asthmaticus, a patient won't be able to even verbalize that. The patient will be using their accessory muscles to breathe. And the patient may even have decreased level of consciousness due to the lack of blood flow to the brain. So remember, you guys, when we are dealing with respiratory issues, remember that we need oxygen for our entire body, including our heart, including our brain. If we go without oxygen and blood flow to those areas, then what happens? That area, those tissues start to die off and stuff starts to happen. So a patient could have decreased level of consciousness. The patient could be cyanosis. So they can experience cyanosis, which turning blue. So what are we going to do, right? So we're going to do, how is this treated? So they're going to do bronchial dilators, epinephrine or corticosteroids. In addition to the bronchodilators described earlier, epinephrine and corticosteroids will be used. So as the nurse, what are you going to do? If a patient is experiencing this, the nursing care steps you should take is to administer oxygen and prepare for emergency intubation and ventilation. So this is something that you need to call a rapid response for, because this can go down very quickly. So just knowing that you're going to use your bronchodilators, your corticosteroids, oxygen, and IV hydration as well. All right, so how are we going to treat asthma? I think this is a nice little mnemonic of asthma. Your adrenergics, your albuterol, your other bronchodilators, your steroids, your theophylline, another bronchodilator, hydration, right? Oxygen, mask. So if a patient is experiencing an asthma attack, 9 times out of 10, nasal cannula is not going to work, and antibiotics if they develop any type of respiratory infection or something like that. All right, so definitely review your medications that could be used for asthma. But one of the things I want to mention, I didn't mention about IV fluids and hydration. Why is this important? So let's think. Let's think of the pathophysiology, what is happening during asthma, right? Well, one of the things is that hydration, that thins the mucus that may be going on with your patient, right? So with the mucus production, it thins out your mucus that they can easily cough it up, and then that could be one less thing that is blocking your airway. But definitely go over your medications, okay? All right. So what are some patient teachings? You want to avoid your environmental triggers, right? If we know that if we know that grass triggers you, then guess what? You need to walk just on the cement, walk on the pavement. Exercise-induced asthma. So for exercise-induced asthma, patients shall use their bronchial dilator inhaler 30 minutes before exercise. And also remember to teach your patients on the emergency inhaler. Patients should always carry their emergency inhaler with them in case they need to use it. Also educate your patient on the difference between your